Hello, I'm Greg Allen. I'm the Chief Executive of Future Care Capital. With me today, I've got Andrew Whelan, our long-serving chair and long-serving trustee, and also one of our longest-serving trustees, Irene Gray, as well. And I'm really delighted to be speaking with you both and having this discussion because between us, I think there's a wealth of experience that we bring to this area around health and care, and particularly in the context of the COVID-19 crisis. For those tuning in, I just wanted to say a few words about FCC. We're an independent charity. We've been around for 70 years. We're all about shaping the future of health and care policy. And we do that through raising the debate and stimulating conversation, working with policymakers, practitioners and others to do that. I think in terms of our focus, we're all about informing people, connecting with them, and how the future of care and health provision can be transformed. And I suppose we look at things through a number of lenses, in particular our work around data and technology and innovation, and also investment. And then we consider how that can be scaled for the benefit of those in receipt of care and working with other partners to do that. So our work is all about insight and research. And today with Andrew and Irene, we're going to have a discussion about a number of things. But for both of you, I just wanted to open up and ask, what was the thing or the things that led you originally to get involved in Future Care Capital?
Shall I go first?
Yeah, thanks, Andrew.
So as you know, I joined Cash as a trustee, and Cash was the sort of the previous incarnation of the charity. And Cash was an awarding organisation focused on childcare and early years, and was looking to expand into social care. As I joined it, we went through a period of change, which ultimately led to selling the business and asset, the awarding organisation business and assets, and I ended up becoming chair of the charity in the wonderful position of a blank sheet of paper, other than our charitable objects, which are to promote education, training, quality and standards in care, health and education, and an endowment in the bank. And so I, with a couple of other trustees at the time who were left over from the previous incarnation, we went through an exercise of deciding what we wanted to do, and alighted on this sort of integration idea of health and care. What has struck me is that the UK sits with two parallel systems. We have a healthcare system which is focused very much on the acute side of things, and we all dip in and out throughout our lives as necessary to be treated, and that's very much where it's focused, acute and treatment. And then we have a social care system which most of us probably don't touch unless we happen to be within it, and that supports people with activities of daily living, perhaps disabled people or particularly the elderly. And it struck me that the two systems run in parallel until the elderly care, where they converge. And elderly care is in other parts of my life where I spend a bit of time, but at that point the two systems converge. But they're not at all integrated. There are different government departments that look after each part of them. There are different regulators for each part of them. They're commissioned differently. They are provided differently. And the political focus is always on what is visible and acute, which tends to be the NHS, and social care is the poorer brother. And I thought there's a great opportunity here to not be a healthcare charity and not to be a social care charity, but actually be something that looks at the whole and tries to look at it from the point of view of the person in need of care, and to try to bring together all the parties who are all working towards the same end, but often working quite an adversarial way against each other because they think they're the only one working for it. And it struck me in my other life that you have these investors, you have these innovators, these entrepreneurs, practitioners, regulators, commissioners, ordinary members of the public, who all want the same thing, which is to provide the best possible care for those in need of care, but all think that the other parts of that puzzle want something different. And actually, I thought there's a great opportunity for us to try and bring all that together. So that's what led me to this.
Great, thanks, Andrew. And Irene?
Well, what can I add? I think, for me, it was, it's been an interesting journey, actually. Having spent now 48 years in healthcare, When Andrew came and spoke to me about his aspirations for this charity and establishing this charity, I thought, this is something different. I've been a trustee in many different charities in the past, and this was really setting up to do something very different to other charities I'd worked with and been a trustee with, particularly with its focus on influencing the joined up or not joined up, should we say, arrangements of health and social care. And it's an organisation that I feel is prepared to tread where others haven't in the past, or if they have, it's failed because it's gone into the too difficult box. So for me, it's been a really interesting journey working within FCC as a trustee and watching the changes and the influences that it's making and is really starting to make now. And I think if I sort of turn it on its head towards my clinical background as a nurse in care of the elderly, the real focus on elderly care for this and social care has been something that I have been interested in for 40 plus years. So it's played to all of those aspirations for me. So that's really why I came to the table. And I think it's now 3 years, I think, Andrew, isn't it? So 3 years ago. So yeah, so that's why I came into FCC.
Great, thank you. Well, I enjoy working with you both and the rest of the board. We've got a very diverse team here, haven't we, in terms of the skills and backgrounds, what people bring, and all other aspects of diversity as well. I think we look at things through different lenses. We've been bringing on board some new people. And I'm certainly here. I mean, I'm in my 3rd year here now, and I remember the opportunity when I first arrived, when I was talking to you about the opportunity, and that has played out. We've got an opportunity here to be agile. You know, you're agile through what you do rather than just calling yourself agile, aren't you? And I think that has played out as we've been moving through the last couple of years, some of the work we've done, the kind of partners we've been working with. So in some ways, maybe that has set us up well to tackle some of the challenges in our world around the COVID-19 crisis, but also the opportunities that come with a crisis, a really difficult crisis such as the one we're currently in. How have you been finding the COVID-19 crisis in terms of your work here and the interests you have outside of FCC? Which I'll go to Irene first on that one.
Frustrating, I think, is the overarching word. Hugely frustrating. But on the reverse side, there's a little bit now that I'm thinking, is this now giving us a catalyst to really significantly change the way we have an integration, or hopefully get an integration between health and social care? Will this act as a catalyst to inform a much quicker review of social care, which we've been promised for years? I think the last promise of a green paper was 2018. And there was one promise before that and promise before that. And of course, like I said about the too difficult box, that's why it's not been produced, in my view. Everything's gone into the too difficult box. So whilst this whole event, as sad as it's been and as difficult as it's been, has created many frustrations, just from language that's used about social care, the way people refer to it. You know, I could go on about that forever, but it has the real potential now that I'm just hanging on there thinking this could be the catalyst that we've needed to really make significant change in how social care is run and managed. And by that, I mean from a national point of view, and how people perceive it. So that's sort of it in a you know, captured how I feel about things at the moment.
Because I suppose the profile of social care has never been higher, really, has it? In spite of, you know, rumination about green papers in the past.
Yeah. Absolutely. Yeah, and the only time it's ever really come to the fore in the past is with things like Winterbourne.
Yeah.
And that's, you know, they have been very sad. But you could say the same thing about the NHS with North Staffs and the things that happen there. You know, there are things, but this now is nationwide. And in fact, from a social care point of view and a care home point of view, it's actually worldwide. And we have a huge amount to learn from everything that's happened across the world. But I would say specifically Europe. I mean, I was listening to Mark Britnell on a webinar a couple of weeks ago, and he was saying that 50% of deaths have been in care homes from COVID-19 across the world.
Yeah.
It's huge.
And it's significant, so significant, isn't it? I mean, I'll come back to you, Andrew, in a second. I think for me, this point about learning from this, even though we're still going through this crisis, you mentioned mid-staffs and what happened in the NHS there and in other places as well. But my concern is that things won't change from this, or they'll even get worse in relation to social care. And I don't say that because I'm feeling negative about it. I say it because I think there's such an opportunity now on the back of what we're seeing play out, particularly around care homes. But let's also remember that social care is not just about
exactly
in care homes. But Andrew, from your perspective, what are you reflecting on at this current time?
Yeah, I mean, I agree with Irene. I think there's frustration. You know, on a personal perspective, I was just as COVID hit, I was on the verge of completing a management buy-in of a small care home group to build a platform, and that was and that fell over. And that was sort of, that particular deal was a culmination of 1 year's work, but it's sort of 5 years behind that to get to it. So that's led to a certain level of frustration. So I spent quite a bit of time since COVID staying involved, and my concerns are that well, I'll start with what I see on the negative side, then I'll say where I think there's some bright lights perhaps. My concerns are that the political focus is necessarily and always on what is acute and also what is most visible. And so what I mean by that is it tends to be firefighting. And therefore, it tends to be a focus on the part of the systems that deal with treatment and acute. So in this case, it's the NHS. So the political starting point was we need to ensure there is capacity in the NHS to deal with a potential flood of COVID cases, because we cannot have it's the first responsibility of government is to protect its people. We cannot have people dying in the streets because we're not unable to provide the support. So necessarily, that's where the focus has been. And what that's meant is that that social care, which can form part of that, has yet again had the green paper and the funding and the long-term strategy kick further down the road. I'm less optimistic about a green paper coming anytime soon and there being any main changes. And the reason I say that is it is a very good thing to talk about. But at the moment, the wealth of the country sits with the people who are about to go into, who are about to hit the age where they start needing social care. And there is little political appetite, I would suggest, on all sides, to actually fund that care for them at the expense of the less wealthy, who can't get property, who are unable to get jobs, who haven't had the same advantages as the wealthy. So funding the generation that's in their 70s and 80s who are seen as having had the privileges as they've grown up. They've had free university education and grants. They've owned their houses and so on. So I think there will be a lot of talk about it, but I can't see that anybody will make that thing. And the other political rationale for not doing anything or kicking it into the long grass is that the benefits of it are not seen within the term of your government. The benefits of it are 15, 20 years ahead, and so there's very little rationale for you to do that, and it requires people to actually think long term. And I just don't think we're culturally at that point. So having said some of those negative things, back to the theme of what's visible and acute. What COVID has done is actually shone more of a light and made social care a little bit more visible and part of the national conversation, and in a way that is helpful to the sector, in that it is not always about crises that appear every so often, of abuse or neglect or whatever, which of course is very rare, which is why they make the headlines. But it's helping people understand what the roles of these organisations are and how they fit in the spectrum, and it's that understanding that will lead to them becoming more visible, and therefore getting more attention. So people have a better understanding now of the importance of mental health. They're beginning to understand or just ask questions about it. I think, one of the common things that we've always talked about is, well, healthcare is free, isn't it? So what do you mean I've got to pay for my social care? But that it's always been the case. It's nothing new. It's healthcare affects everybody at some point in their life, so we all understand it. Social care, people just it is not something that people experience, so they don't understand the system. And we saw that at the last election, where a policy that was demonstrably 4 times better than the current situation was dubbed the dementia tax, and the government lost an election on the back of it by putting a policy in place that is 4 times better than the current thing in terms of numbers. But that was because people don't understand the current system, and they didn't understand that that's what it was, because it's complex. So I think this is the start of it, and I think that that we as FCC and others can help with that education process of what do all these pieces do within the system. As Irene said, there have suddenly been opportunities, things that we've been talking about for decades. Bed blocking in the NHS, getting people out of acute beds who don't need to be there because they're medically fit to go home, but they need a package of care to help them, and are stuck because they're not, because there isn't capacity, but hasn't been the capacity within social services to support that package. Suddenly removed out of beds within 3 weeks to free up the capacity in the NHS, because that became the problem. And all the agencies around this, the regulators, the commissioners, the providers, actually galvanised against the common enemy and finally worked together and made these things happen. The use of technology to free up capacity within the health sector. GPs and patients having previously been resistant, and indeed myself, everybody resistant to doing these sorts of Zoom conversations or video conversations as opposed to in person, suddenly completely flip the other way because we have no other choice. And my hope is that, and perhaps it's gone too far in a lot of respects, but my hope is that actually the new normal will not be a return to the old ways, but it'll actually be a return to some sort of balance and equilibrium, of using the right tool for the right jobs. You don't need to be seen in person if you can be seen over Zoom, and that obviously also brings in technology applications for having vitals or whatever being read at home, so you don't need, the doctor can read them, then you don't need to go there to have, or whatever it might be. So I think there are opportunities. I just hope that we can not just slip back to the old way, because that's what we're used to.
Sorry, Irene. Yeah.
No, I was just going to say, and if I may say on the back of that, I totally agree with everything you said there, Andrew. Is that there's always talk at events like this and occasions like this. So what are the lessons learned? We know from experience and from the past, setting up committees to review what's gone on and prepare reports, etc., can take years. My real wish, is that something is done quickly, and that let's take the lessons learned from this now, from the technology point of view, from the successes that some places have had, from the relationships that people have developed. Let's not lose those things. Let's take it now. And there's got to be clear evidence around the UK of where it's worked well and where it hasn't worked well. So if we're going to influence the future of this sector in any shape or form, we have to draw on that now and do it quickly.
Yeah,
I don't want to be sat here in another 5 years' time saying, oh, the report's coming out soon.
I agree.
Sorry, Grace, I was going to say,
in terms of the work that we're doing at Future Care Capital, data has obviously been central to a lot of our work, and that's been one of the areas that you could probably describe as a block, and some of that is understandable because of the rapid pace of change around access to and value of an understanding of health data as opposed to, you know, what we have with social care data. And there are a lot of things going on even as this crisis progresses to improve the social care data perspective. But as we in the public watch the nightly briefings from the government, it's been very clear, hasn't it, around the issues to do with data. And I think that at Future Care Capital, we often describe ourselves as a think and do tank. And in that respect, our work, I think, can be a catalyst for getting some things moving. And we're already, I would like to say we're already doing that. And we're seeing the benefits of some of our research in terms of influencing the debate around how social care data, access to it and use of it can be improved. Andrew, I know I think you had another point there, but can I just stick with the data bit for a second? In terms of the challenge we have been talking about and the way the government's handled it and where we're going with social care data, what are your views on the opportunities, not just for Future Care Capital, but much more importantly for other organisations, for people on the ground in this respect?
If I may, I think the social care sector would welcome clarity around what data is being collected, what data is of value. And I say that because we know, for those of us that work in the sector, that there are so many variables that are being counted. So it creates a cloudy picture. And a simple one, as awful as it is, are deaths and deaths related to COVID-19. So, and you know, there are masses of examples of residents who have died who've never been seen by a GP because they've had a temperature, it's been classified as COVID-19. We'll never know if it was or it wasn't. You know, you've got residents who are end of life, who are deteriorating quickly. They've had a bit of a chest infection. COVID-19's gone on their death certificate, yet they went to that care facility for end of life care, which could be days or weeks. More often than not, it's days. So, you know, I think the sector would very much welcome some real clarity about what they can give, what can be done to make sure everybody's counting the same thing. Because the data is only valuable if it's being counted the same. And we're too far down the line now with this, with COVID-19, to be able to extrapolate which were, which weren't, and all the rest of it. And so at the end of the day, this is going to be a very much possibly this is the number, and you know, separating out those that may have actually died from COVID-19 and those who died as a consequence of COVID-19, i.e. not being able to get into hospital quick enough, or because, you know, other variables, we just won't have that data at this point. And I think it's going to be very difficult to get that. So going forward for the future, creating a national framework that will say this is the data that everybody needs to collect. I am 100% convinced that the social care sector will buy that. And
of course, the data analytic modelling capacity and capability to do that as well. Yes. So much about people. And we do, the funny thing is, with the challenging thing is that we have a lot of that data out there, don't we? It's just not joined up. And we have some great people working on this out there, but it's the joining up bit, coming back to the point at the beginning of this piece about integration. Andrew, I know you wanted to come in.
Yeah, I mean, on that point, I think you're absolutely right about the amount of data that's in there. And one of the problems the sector has is the social care sector has is the amount of data that they need to collect on a daily basis anyway for various regulatory reasons and so on, and the medium in which they collect it. So you have multiple agencies requiring data, often different or often almost the same, but it needs to be in specific formats. So you're constantly administrating the same information but in different formats, and in a lot of cases, particularly in in elderly care, the sector is not large corporates who have deep pockets. The majority of the sector are mom and pops who own one or two care homes or one or two branches of domiciliary care or whatever it may be. And a lot of their work and their margins are really tight. They don't have the money to invest in it. They don't have the deep pockets to invest in it, or indeed manage COVID as it has come along. But a lot of it is still done on paper, because when they hand something over between their systems and the hospital, for example, or the GP, the only way that the two systems talk is because there's a file of paper. So one of these care home groups that I looked at, they had invested a fortune in all singing, all dancing IT systems that would really support the workforce to be efficient and to provide whatever data and things they needed. But everything was written on paper, and then somebody filled it in on the system later. But they never had time to fill it in the system, so everything just stayed on paper. So those are some of the challenges that need to be overcome. And then there are some other practical challenges, like actually the infrastructure. Another group I looked at had rolled out sort of model of care, but it was lever arch files as opposed to an app. But it had been designed as an app, but they had to roll it out as lever arch files because a good proportion of the homes didn't have the broadband infrastructure to be able to log into the central computer, or they barely had one computer in a care home. So it's not big technology that's the first step. Is actually some of the basics. And perhaps COVID, because we're all now working from home and needing these facilities, perhaps that will support the rollout of infrastructure that we desperately need.
Thanks, both. So we've talked there a lot about local planning and social care at a local level. And that brings us to the end of this particular episode. But in the next episode, we'll start by looking at things more from a national perspective, and where national policymakers, the government, for example, are making decisions. Thank you.